If ammonia is elevated on a board question, that is not a random lab, it is a signal and it points you to a very short list of diagnoses. Boards don't casually give ammonia. When ammonia is high, they are telling you what category of disease you're in. In this video, we're going to use ammonia as the anchor to understand why it rises, which inborn errors of metabolism can cause it, and how boards want you to differentiate them. You don't need to know the pathways, you need to know the patterns. Ammonia is a neurotoxin. The body's primary way to get rid of that ammonia is through the urea cycle. So if ammonia is elevated, one of two things is happening. Either the urea cycle itself is broken, or something is overwhelming or inhibiting it. That distinction is the backbone of this entire topic. The first question you should always ask is whether metabolic acidosis is present. High ammonia without metabolic acidosis points towards a primary urea cycle disorder. High ammonia with metabolic acidosis and ketones points towards organic acidemia. That single fork in the road is going to dramatically narrow your differential. Urea cycle disorders cause direct failure of ammonia detoxification. Boards might describe a newborn or a young infant with vomiting, lethargy, poor feeding, respiratory alkalosis, and very high ammonia levels. Importantly, no metabolic acidosis. This pattern should immediately raise concern for a urea cycle defect. The board favorite is ornithine transcarbamylase deficiency, OTC deficiency. This is X-linked recessive and often presents severely in the neonatal period and causes marked hyperammonemia. Boards may also mention elevated orotic acid, which occurs because excess carbamoyl phosphate spills into pyrimidine synthesis. The key point is that ammonia is high. That keeps the diagnosis in urea cycle territory, not necessarily pyrimidine territory. It's important to contrast OTC deficiency with orotic aciduria. Both have elevated orotic acid, but ammonia separates them. In OTC deficiency, ammonia is elevated and neurologic symptoms dominate. In orotic aciduria, ammonia is normal and the hallmark is megaloblastic anemia. If an ammonia is high, orotic aciduria should fall down your list. The second major category to think about is the organic acidemias. These don't primarily affect the urea cycle, but the accumulation of organic acids inhibits it secondarily. That is why ammonia rises along with metabolic acidosis and ketones. Boards will often describe an early infant with vomiting, lethargy, acidosis, ketones, and elevated ammonia. When you see ammonia plus acidosis, you should pivot to organic acidemias. There are 3 organic acidemias that the boards love. The first is propionic acidemia. This is caused by deficiency of propionyl-CoA carboxylase, which is a biotin-dependent enzyme. Clues here are going to include severe metabolic acidosis, hyperammonemia, cytopenias, and symptoms that worsen with protein intake. If biotin is mentioned anywhere in the stem, propionic acidemia should rise to the top of your list. The second is methylmalonic acidemia, which is caused by deficiency of methylmalonyl-CoA mutase or vitamin B12 deficiency. Boards may mention metabolic acidosis, hyperammonemia, neurologic symptoms, or elevated methylmalonic acid levels. If B12 is mentioned, or if the disorder improves with B12 supplementation, methylmalonic acidemia is the best answer. The third one is isovaleric acidemia, which is caused by deficiency of isovalyryl-CoA dehydrogenase. Boards often make this one straightforward by mentioning a distinctive sweaty feet odor. If there's a smell in the question stem, boards are essentially handing you this diagnosis. Here's the fast board algorithm. High ammonia without metabolic acidosis points to urea cycle disorder. High ammonia with metabolic acidosis and ketones points to organic acidemia. Once you're in organic acidemia territory, look for one extra clue. Biotin for propionic acidemia, B12 for methylmalonic acidemia, or sweaty feet for isovaleric acidemia. You don't need any more than that. Hyperammonemia also helps you rule things out. If ammonia is elevated, you can usually exclude glycogen storage diseases, fatty acid oxidation defects, and isolated pyrimidine synthesis disorders. Ammonia keeps you in a very narrow diagnostic lane. The takeaway is that ammonia is not just a lab value, it is a sorting tool. When you let ammonia guide you, entire answer choices are going to disappear and metabolism questions stop feeling like guessing. When ammonia is high, trust it, let it tell you where you are and where you are not. Let's talk about this case example. We have a 4-day-old newborn who's brought to the emergency department for poor feeding, vomiting, and increasing lethargy. The infant was born at term after an uncomplicated pregnancy and delivery. There were no perinatal complications, and since discharge from the hospital, the parents report the baby has been difficult to arouse and has fed poorly. Now, the timing matters on these things. When a newborn becomes symptomatic within the first few days of life, I am immediately thinking about inborn errors of metabolism. Also sepsis, but inborn errors of metabolism are cannot miss. On physical examination, the infant is hypotonic and minimally responsive. Vital signs are normal, and labs reveal a markedly elevated plasma ammonia level. Blood glucose is within normal limits, and an arterial blood gas shows no metabolic acidosis. Urinalysis is negative for ketones. Which of the following is the most likely underlying cause of this patient's condition? Is it a defect in branched-chain amino acid metabolism, a defect in fatty acid beta oxidation, defect in the urea cycle, glycogen metabolism, or purine degradation? Let's go back and look at this part of the stem. When I look at the labs, the key abnormality here is a markedly elevated ammonia level. Blood glucose is normal, there's no metabolic acidosis on the blood gas, and the urine is negative for ketones. That combination is extremely high yield. When you see isolated hyperammonemia without metabolic acidosis or ketosis, that should immediately point you toward a urea cycle disorder. Organic acidemias typically are going to cause metabolic acidosis and ketosis. Fatty oxidation disorders cause hypoketotic hypoglycemia. Neither of these patterns is fitting in this case. So at this point, the diagnosis I'm thinking about is a urea cycle defect. In these disorders, the body can't effectively convert ammonia into urea for excretion. As the ammonia builds up, it becomes neurotoxic, which explains the lethargy, hypotonia, and the poor feeding that we're seeing in this infant. The big takeaway is that ammonia itself is the problem. Elevated ammonia levels cause rapid neurologic deterioration, especially in newborns, which is why this presentation is so severe and so early. So the most likely underlying cause in this case is a defect in the urea cycle. Let's go through the answer choices and eliminate them one by one. Choice A is a defect in branched-chain amino acid metabolism. That would describe an organic acidemia, like maple syrup urine disease. Those disorders typically present with metabolic acidosis and ketosis, not isolated hyperammonemia. Since this patient has no acidosis and no ketones, the choice isn't fitting. Choice B is a defect in fatty acid beta oxidation. Fatty acid oxidation disorders classically cause hypoketotic hypoglycemia, especially during fasting or illness. In this case, the blood glucose is normal and the ammonia is the primary abnormality. So again, this one can be eliminated. Choice C is our defect in the urea cycle, which fits perfectly. We have isolated hyperammonemia, neuro symptoms like lethargy and hypotonia, and a rapid clinical decline. The absence of metabolic acidosis and ketosis is a key clue that's pointing to this diagnosis. Choice D is a defect in glycogen metabolism. Glycogen storage diseases cause hypoglycemia and hepatomegaly, but they do not cause severe hyperammonemia as the primary abnormality. That pattern just doesn't match in this case. And choice E is a defect in purine degradation. Purine metabolism disorders are associated with problems like gout or immunodeficiency, just depending on the specific enzyme, but they are not a classic cause of isolated hyperammonemia in a newborn. So when you eliminate the choices that don't match isolated hyperammonemia without acidosis, your best and correct answer is a defect in the urea cycle.